People will always come and go in our lives, but we all know those few who never left, because they always leave you with so much more. The ones who make you stronger, build you up when you're broken down. The partners who've always had you covered. At Blue Cross and Blue Shield of Texas, we know what it means to be covered by someone you look up to, even when they're sitting right beside you. To be covered by someone guiding you through more than just the routine. To be covered by that friend you consider the best because that's how they make you feel. At Blue Cross, we know what it means to be there, guiding you toward a healthier state of mind. Because the more we know as individuals, the healthier we all feel as a community. Through it all.
Lone Star College is one of the largest community colleges in the nation, serving more than 93,000 students. Our ability to deliver the highest quality education and training to the widest population is always improving. First delivering online courses in 1997, Lone Star College now enrolls more students in online courses than any other college in the nation. In addition to our robust online certificate and degree options, we are the first college in Texas to offer registered apprenticeship programs. As a community college, our mission is to put students on the path to success and advance our entire community, resulting in a $3 billion economic impact in the Houston area. Lone Star College makes education accessible and available to all. We serve the largest Hispanic student population in the nation and are the second largest provider of associate degrees to Hispanic students in the United States. We are committed to bringing value to our students and to the community through the expansion of education. Through innovative and relevant programs, Lone Star College succeeds in its mission, delivering wide-ranging opportunities that change lives.
I'm Karen Brooks Harper, Health and Human Services reporter for the Texas Tribune. Thank you for tuning in for our conversation about the lasting impacts of the COVID-19 pandemic on Texans. I'm joined today by Dr. Lauren Ancel Meyers, Dr. John Carlo, and Dr. Iván Meléndez. Professor Meyers is the director of the UT COVID-19 Modeling Consortium and the Cooley Centennial Professor of Integrative Biology and Statistics and Data Science at the University of Texas at Austin. Dr. Carlo serves as the Chief Executive Officer for Prism Health North Texas and President of the AIDS Arms Physicians, Inc., the largest nonprofit community-based HIV/AIDS healthcare service organization in North Texas. Dr. Meléndez has served as the Medical Director for the Hidalgo County Health and Human Services Department, the local health authority for Hidalgo County, for the past 15 years. Let's get started. In the past year and a half, more than 2.5 million Texans were infected with COVID-19 and more than 51,000 died. Schools shut down and millions of people lost their jobs and access to health care, most of them already economically disadvantaged or people of color. All of this and more, and it's not over yet. We'll be seeing impacts and scars that will likely never go away. There's no question that the pandemic changed us and our state. The question before us now is how. Dr. Meyers, let's begin with you. One of the projects your team is working on is a close look at the geographic and socioeconomic disparities in the impact of the virus. Why is that a focus now? And is healthcare inequality something you expect to see more attention paid going forward?
Yeah, thank you. It's very nice to be here. And I think you summarized really well the devastating impact that this pandemic has had throughout Texas. And over the last few months, really since the beginning of 2021, we have refocused our attention from just sort of the urgent need to explain what this pandemic was, come up with effective mitigation strategies, to really looking in more detail at the disparate impacts and how to close certain gaps. And actually just this week, we're releasing a new dashboard on our COVID-19 Modeling Consortium website that looks closely at the city of Austin at a zip code level, at the impact that it's having and the disparities. So we look by zip code at how many people have died from COVID, how many people have been admitted into hospitals over the last few weeks, and how many people have been vaccinated to date. And what we see is that there's a really strong correlation between a community being vulnerable and a community having high fatality rates, high hospitalization rates, and lower access to vaccines. The CDC measures zip codes in different communities using something called the Social Vulnerability Index. And it is a quantity that tells us something about how resilient a community is to threats like pandemics, to natural disasters. And when we look specifically at this vulnerability index, we see that our most vulnerable zip codes are a good 2 months behind our least vulnerable zip codes in terms of access to vaccines. And the impacts are not just in terms of the direct impacts of COVID. The impacts are also in terms of lost education, in terms of housing instability and increased homelessness. And so these are impacts that, and let me also mention, for those communities that have sustained more COVID infections, they're also going to be suffering from the long-term effects of COVID for the foreseeable future. And so we see not only that COVID has been devastating in the United States, but it's disproportionately devastating in our most vulnerable communities. And this has to be a focus going forward. Not only how do we close the gaps, how do we remedy what's happening with COVID, but how do we ensure that our more vulnerable communities are less vulnerable, not just to COVID, but to seasonal influenza, to other viruses, and to future pandemic threats.
Thank you. Dr. Meléndez, as a physician and public health director, you were on the front lines in the Rio Grande Valley. What made those residents so vulnerable in your area? And is there anything that can come out of this that will make them less vulnerable to something like this in the future? Or will the pandemic change things for the worse, or not at all?
That's an excellent question. I also want to mention my being grateful for allowing me to share our experiences with you. And absolutely, to follow up what Dr. Meyers said, we are always number one or number two in obesity, diabetes mellitus, and hypertension. The average rate of access to healthcare in the United States of uninsured or underinsured is around 10%. Texas is among the lowest at 19%. And the Rio Grande Valley, being number one or number two in poverty year after year, we have 40% of our population that is either uninsured or underinsured. It's no wonder that about a year ago, we were leading the nation with the infamous statistic of having the highest mortality rate. We had 5% of our people are infected, not 5% of the people that were in the hospital, but 5% of the people that were infected ended up succumbing and dying. I can't tell you, even though our population is 1.2 to 1.5 million, I think that's what will be re-upped. And that's not including all our folks living underneath the count, since we're our number one migratory center for people coming from South America and from Mexico. But despite those numbers, we were devastated. Absolutely. The question for us was, we're not the only border town, and we are a sophisticated medical community. We have medical schools, we have kidney transplants, we have liver transplants, we have 1,500 physicians in Hidalgo County alone. There are 9 hospitals. It is probably the second or third leading industry, healthcare. And so by no means will we consider, at least as a practicing physician, an underserved area as far as accessibility healthcare. So what made us different than Laredo, than Harlingen, than Brownsville, the Eagle Pass, and El Paso? That was a question that we put before us, because we were by far doing worse than other folks. And contrary to that, and a little bit of opposition, what Dr. Meyer was saying, now we're among the leading communities in vaccination. In fact, we've been leading the entire state, those of us on the border, in Hidalgo County specifically, approaching 50% of all people being vaccinated. So for us, the question was, what made us the worst of the worst? What made us the most vulnerable? And why are we seeing such high success rates with our vaccination programs? Remember, at this time a year ago, we were getting close to 70 people dying a day. And we have days where nobody dies, 1 or 2 a day. We had 1,200 in the hospital. Today, we have 48. And so our numbers have dramatically improved. There's no doubt it's directly related to the vaccination. So the real question is, why? What happened to us? What made us the most passionate? What made us the most vulnerable? And I can tell you, I've been doing this for 30 plus years. Afghanistan, Iraq. I was on the forefront of HIV when it first started. HBO, Showtime. I've been doing this for a long, long time. And I can tell you that the answer is easy. Those comorbidities are associated to mortality and a terrible outcome. We were the leaders. If you're morbidly obese, diabetic, and hypertensive, if you only have 40% access to healthcare, our baseline state of health in Hidalgo County was worse than Willacy County, Cameron County, El Paso County. So unfortunately, in our community, we have 2 free clinics. Imagine 2 free. And the mindset, my mother, your mother, another mother at a party, oh, my son's a family doctor. That's nothing. My son's a cardiologist. That's nothing. My son's a neurosurgeon. So those things that were not considered sexy, like diabetes and hypertension, that took a back seat to liver transplant, kidney transplants, we were hurt. And so the lesson learned for us a year later, the most important lesson is that we need to access our community to have better baseline state of health through legislation, through funds for our elected officials, culturally, philosophically. And for us, because 85 to 90% of our population is Hispanic, it's difficult for us to see among our own community disparities from finance or zip codes, because we're all Hispanic, we're all poor, and we're all living in the same area. And so for us, we're kind of monolithic in our own community.
Yes, thank you for that. And the question about vaccines is something I was going to bring up and ask you to elaborate on it in a little bit. You share a public health background with Dr. Carlo, who's now in the nonprofit center, but in a previous life oversaw Dallas County Health Services. Dr. Carlo, what strengths or weaknesses in the state's public health system did the pandemic show us? And what sort of structural, financial, or other changes might be afoot or should be, in your opinion, as a result of what we've seen in the last year?
Well, first, thanks for having me on this great panel. It is a pleasure to be here and continue this dialogue that's absolutely essential. I think to look at successes, we have to go way, way back to the very, very beginning. And I think that there was some critical moves, at least what I was a part of in Dallas, that was absolutely essential. And what that was about was when we first started seeing cases, we had the local ability to do stay-at-home orders. And I think I can tell you from the Dallas situation, and I know in Houston as well, without doing that stay-at-home order, what would have happened, it's hard to even think about, but what would have happened is we would have overrun our hospital capacity and we would have run out of beds to take care of people. The second thing that I think is an absolute success that we've got to talk about is that our hospital system all of our healthcare workers in our hospital systems were just absolutely amazing during this critical time. I sit on a local task force that has been for years talking about what happens if we were to ever run out of ventilators or not have enough supplies to take care of people. And I will say that when we were meeting during these critical times, particularly in early on and in January, we were a day away from running out of the ventilators. We were really at the brink. And it's really scary to think about it, but we managed to not go over that cliff thanks to some incredible ingenuity in our healthcare system. Just the folks on the ground doing all that hard work, in Parkland, setting up the COVID ward, really going through all of this process with critical care, it truly saved lives. And so I do think that this is one of that critical success points that we have to recognize. It was the local decisions that were made early on, and it was the healthcare system that responded, I think, in an admirable fashion. With that all being said, we've got a lot to work on. And I think that overall, our healthcare and public health infrastructure really shows where we were in terms of our vulnerabilities. We've had decades and decades of underfunding in local, state, and federal public health. And this is really the product that we receive when we take for granted, I think, what is the big measurement of how we keep our communities healthy. We often confuse healthcare with public health and sort of neglect the overall thing which saves lives. And really, it's not the healthcare, it's public health. We really haven't been able to do much in terms of healthcare, even until after World War II, when we actually had good things like antibiotics and all the things that we did, have today. But really, the life expectancy and how we've improved health went way, way before that and should continue today. And so, going forward, we really do need to look at the public health infrastructure in this state, both locally and at the state level, to make sure that we have the right tools and capacity to respond to an inevitably what will be another pandemic event in our near future.
Thank you very much for that. Dr. Meyers, here's a question from one of our readers. Annette asks, how is Texas better prepared for another outbreak or pandemic? What sorts of things should scientists and state leaders consider as we look ahead to the next one?
So this is not just true of Texas, but the whole United States. While there certainly are things we did well on, there are so many things that we could have done better. I mean, it's tragic that over 600,000 people have died from this pandemic in the United States, and I believe many of those deaths were preventable had we made different decisions before and during the pandemic. And I think at the largest scale, we really have to, as a society, as a state, as a country, overcome our collective failure of imagination and thinking about what kinds of pathogen threats, what kinds of viruses, what kinds of diseases may be coming down the pike in the years and the decades ahead. I've been working in the field of pandemic preparedness for my entire career, for about 20 years. And I'm a modeler. So we build models that simulate what pandemics might look like, with the hope of using those simulations to come up with better plans, make sure we have the resources in place, make sure we have enough ventilators, make sure we have the right action plans, depending on what the threat looks like. And I will say that even though we have, as a global health community, have been thinking about pandemics for decades, we never anticipated that we would need face masks, that we would need stay-home orders, that testing and diagnostics would be so essential to save lives. And we didn't have those test and trace programs in place. We didn't have the stockpiles of everything we needed. And so I think one thing we need to do is really step back and think about not just what the threats we know about, influenza, coronaviruses, but what other types of viruses may threaten the global community, and what might they do to people when they infect them, but what are those cascading societal impacts? How are future pandemic threats going to impact education? How are those threats going to impact housing stability? How are people going to behave, and how are policymakers going to make decisions? What kind of information do they need? There's a lot of what happened in the pandemic came down to politics, came down to individual decisions, came down to behavior, came down to belief systems. And so we need to come up with better systems for understanding and making rational decisions to protect lives and protect our socioeconomic well-being during threats. And so this means, planning, coming up with better plans, but it also means really investing more resources into our public health systems around the country, making sure our public health systems have the knowledge, the personnel, the preparedness in a sustainable way. It's what I've seen after past threats, after the 2009 H1N1 pandemic, after the Ebola and Zika threats about 5 years ago, that there was a lot of interest for a short period of time, and then those funds got diverted to the next threat, and there wasn't really sustained investment in preparing for what might be coming our way. So better investment in public health, better planning, thinking outside the box, what kind of threats we may be facing, and what their cascading impacts might be on our society as a whole.
Dr. Meléndez, I see you nodding up there, and I wanted to ask you kind of the same question. Is Texas better prepared, or are our leaders going to remember what happened?
I mean, imagine intubating your sixth grade school teacher. Imagine going to funerals where everyone stays in the car and no one can get out. Imagine walking in freezers with 70 cadavers. Imagine waiting 3 weeks until you have the opportunity to be buried. Everyone has been deeply impacted, and therefore, from an emotional perspective, this cannot be forgotten. We're absolutely changed. You know, it's a lot easier to be happy when you're 20 years old than when you're 50 because your mom hasn't died, you haven't gotten sick, you haven't had a life-threatening thing. So as we suffer, unfortunately, it's my opinion that pain is a great motivator for us Homo sapiens to make changes. My experience is a little bit different than your other two panelists. You know, I was directly where the rubber hits the road. We didn't have stay-at-home orders because everything was politicized. We didn't have the individual capacity to keep people at home. And how do you stay home when you make $300 a week and you have to feed 5 people? And so a lot of it is nice in the planning perspective, and I would agree that models are incredibly important so we can have a better idea. But I think we need to temper everything with what really is going on where the rubber hits the road. And where the rubber hits the road is people need to work, people are going to go to school, people are not going to listen. We saw very minimal behavioral changes. The only impact that we saw that really was measurable was the vaccine. We were still fighting people to wear masks and wash their hands, and there was some behavioral change, but not dramatic. So we've absolutely changed. All of us, including myself, with 30 plus years of experience in this clinical field, cannot leave this unscathed. You cannot leave this with that mark of what can we do better and what have we done. And by all means, a big change that I think has occurred, at least from a intellectual perspective, is that we need to be in a better baseline state of health, period. We need to have, and I hate to use this word, but we need to have more equity in getting access to not being obese, to not being diabetic, but not only financial resources. It's great to say we need these many ventilators and we need this many nurses, but we don't have the human resources. We don't have the physical plants. We don't, right now, as a result of what happened, the nurses were their salaries changed so dramatic to go work somewhere else. They had life-changing salary. And so now we have a tremendous deficit of nursing care. So even if we plan to have X amount of human resources, they're just not available. And so this occurs 10 years before a person becomes a nurse, before they get into a healthcare. So you have that amount of, folks that are available to do this work. So my perspective is that we need to pay attention to those idiosyncrasies that actually occurred. The politicization of the whole system, having a Democratic president with a Republican governor with a Democrat local government, the withholding on funds, what we perceive based on some political biases, that there's no doubt that occurred. The idea that you can have a great plan in place, but if you don't have the resources to hold it up, you can't put it in place. And so I would say that we've changed, we're better prepared. And the lesson that we've learned as a healthcare system, at least in my part of the state, is collaboration. We've learned to collaborate. As you know, in countries where medicine is a public or a national, like Israel or Chile or these places, it's easy to get 1,000 clinics to say you're going to vaccinate, you're going to do this. But in a private system like in the United States, you have to have the collaboration of the local health departments, the state health departments, universities, the schools. and also private industry. We need to get the private doctors and private hospitals, which we were fortunate to do, to participate. Otherwise, if you do not have that collaboration, it's not going to happen. And because we've had chikungunya, Zika, malaria, all these tropical diseases down in South Texas, we were fortunate to have established these relationships with school districts and local clubs and local hospitals. So we already had a previous experience of how to collaborate between private and public industry, which it's a mandate. You absolutely cannot be successful without having all three pieces of that puzzle work together.
Dr. Carlo, I'll ask you the same question, but in the context of your current work with the HIV/AIDS community. HIV/AIDS is now a 40-year epidemic with no cure in sight, and there's no question that it changed our world in terms of behaviors, education, health policy, and attitude. Translate, if you would, those types of impacts to the coronavirus pandemic. Do you see any societal shifts coming as a result of the pandemic to the extent we saw it with the various outbreaks and pandemics we've seen in the past few decades?
Well, I can talk about the first part of the experience, particularly with our patients living with HIV and many of our staff and the community that we work alongside with. You know, when this happened, I think the term haunting was used quite frequently because many people who were survivors of the HIV and AIDS pandemic saw this as just really, there was a lot of just parallels, particularly early on. And many people were very, very frightened, you know, that the experience was, you know, I've lived 40 years with HIV and I don't want to die over the weekend with COVID. And so there really was a strong emotional part to this experience. And I think that there is a lot of lessons to learn when we start really thinking about these different pandemics and how they really impact different people. You know, the fascinating thing about viruses is that, you know, the human being, everybody is susceptible equally, right? You know, we're all human hosts and the virus really knows no differences between all of us, but yet these pandemics have not affected everybody equally by all means. And, you know, we looked at the HIV and AIDS pandemic in particular and in the different groups that have been disproportionately impacted. Again, with the coronavirus, the same thing. You know, we're seeing very, very strong ties in different places where really, I think we can see where we're at our most vulnerable. Oftentimes, you know, if we look at HIV and AIDS, it's about stigma, lack of education, lack of access to healthcare. This is what's fueled the HIV and AIDS pandemic here in this country. You know, COVID has had the comorbidities as we've been talking about. And so I think there's strong parallels. But the one thing I'm worried about, I guess, at the end of the day, and I think we've seen this too much today with HIV and AIDS, and this question of, you know, will we remember and will we learn from this experience? I worry because I think, unfortunately, maybe it's perhaps our human nature, maybe it's evolution itself, but we tend to move on very, very quickly. We could call it perhaps short-term memory. But, you know, when I was doing lectures on pandemics back after the SARS situation, I always asked the room, how many know of a relative that died in 1918? And very, very few people would raise their hands. And it's remarkable because just from the statistics alone, if you have relatives that lived in the United States during 1918, you would have known somebody very likely that would have perhaps died or have had somebody in your family. But yet that memory was gone by just a few short generations. And, you know, HIV and AIDS is the same way. We call it complacency today. We don't really see the same level of awareness and prevention that we have today. So, you know, I hope this is not the trend for COVID. I hope that we do stand up and say, you know what, we have to do something different, particularly about where we've experienced our most vulnerable and where our biggest challenges were. But I do think it's not going to happen automatically. I think human nature, unfortunately, will slide us away and move us without really strong emphasis towards making a difference. It's not going to happen by itself, unfortunately.
Building off of that, Dr. Meyers, how can the scientists like yourself kind of keep it in the forefront? For you worked with a lot of the local leaders to develop some of these systems. Do you see your role and the role of those like you as helping kind of with the longevity of keeping this in the consciousness of our political leaders going forward?
Yeah, one of the key roles that scientists like me play is in trying to understand what has and hasn't worked, and taking lessons learned and incorporating them into thinking about how we would respond to future threats. So, we talked earlier about how we're looking at disparities, and this has come up a lot, thinking about why did Hidalgo County, or why has Hidalgo County experienced more than 3 times the deaths of Travis County and Austin. Those are huge disparities. Why is East Austin facing, double the death rate from West Austin? And so that's one thing we're looking into, and we've talked about a lot. It's not just about, a huge part of it is the higher rate of these underlying comorbidities because of chronic lack of access to healthcare. It's also about increased exposures, people who could not afford not to go to work. It's about failure to communicate effectively, about the beneficial use of face masks, about the importance and safety of vaccines, et cetera. So there's that part of it. But the other thing that we have been really intensively involved in, at least in Austin and some other parts of the country, is in designing data tracking systems and decision-making paradigms that really are try to balance these two competing goals. We want to protect health and safety. We want to have good public health outcomes, but at the same time, we don't want there to be huge socio and economic costs. People need to be able to eat. They need to be able to go to school, et cetera. And so we have developed some really interesting approaches to designing what we call staged alert systems. So we have these in many cities and states and even countries across the world, where you'll see, these different, for example, color codes. When we're in red, we need to shut down. When we're in orange, we need to enact stricter measures. When we're in yellow, we can relax. And so we've developed strategies for, tracking data to let us know exactly when we need to tighten measures, exactly when we can loosen measures, in order to make sure we have enough ventilators, make sure we have enough hospital beds, but at the same time, not avoid overkill, avoid forcing people to stay home when they don't need to. And so one of the things we're looking at now is, which systems worked, which systems didn't work, which data was reliable, what data was not reliable, so that, next time we have a threat, we don't take a whole year to figure out, what is the data telling us, and when should we respond, and when should we, and it becomes less politicized and just more grounded in our historical experience and science.
Thank you for that. While I have you, our reader Barry asks, what is the probability of a resurgence of COVID-19? We're going to shift gears a little bit and go into a little bit more clinical here for a second. And how likely are we to go back to mask wearing if we don't obtain herd immunity? Dr. Meyers, I think you could probably answer this question too in the same answer from another reader, Una, who asks, what are your concerns, if any, about the potential impact on Texas of the Delta variant?
Yeah. These are the questions of the moment. And one thing that I have said throughout COVID, and we on our website at UT, we have multiple different dashboards for forecasting what is COVID going to do in the coming months. And one thing that we always say is that we understand a lot about this virus, how it spreads from person to person, but we don't have a crystal ball about human behavior. And without knowing how people are going to behave, without knowing how many people are going to get vaccinated before the end of the summer, it's really hard to make forecasts. But we can talk about scenarios that are plausible. So, if we are likely not going to be able to vaccinate children under 12 before the end of the summer. And it's also unlikely that people are going to voluntarily wear face masks sort of religiously once kids start going back to school. So I would not be surprised at all if the return to school in the fall, the return of college kids to campuses across the state, fuels another surge in transmission. The hope is that even if that does happen, enough people in our vulnerable groups have been vaccinated so that we don't see the same level of hospitalizations and deaths that go, if we do start to see increases in transmission. So I would not be surprised at all if we see resurgences in the fall. I'm hopeful that they will not be as catastrophic in terms of loss of life and loss of livelihood. As far as face masks, face masks, it turns out, even though they haven't been widely adopted everywhere, face masks turned out to be a really low cost effective measure for preventing transmission, right? This is not something that forced you to stay home. You didn't lose salary. You could still even go out and do things that were social. And so it was sort of almost a free option that could really slow transmission. So, my hope is that the face mask issue becomes depoliticized, in the coming months, and that face masks actually become a very normal way of protecting ourselves against not only COVID, but seasonal influenza and other respiratory viruses that spread when people talk, cough, and sneeze around each other. So, it's going to be sort of it's going to be a challenge to overcome the political, the behavioral impediments to it, but it is a really effective measure that hopefully will become normalized in the coming months and coming years.
Dr. Carlo, do you see any behavioral or mental health issues becoming long-term problems in the wake of the pandemic? And is Texas prepared to handle them?
I do. And I think we should be really, really worried about this. And this is probably, unfortunately, the next chapter, and why I don't think it's fair to kind of say, we're going to be sort of finished with COVID or sort of say the end of COVID or the end of the pandemic. We're on a baseline of having a huge behavioral mental health problem in the state. Our communities simply do not have the resources to manage the number of conditions and the treatment that's necessary really for our community. And so that's our baseline. And now we look at the added effects. So we're talking about substance use, addiction, the lack of treatment for both of those conditions, depression, anxiety, all of these conditions that will be further, worsened by this experience, not only of going through the stress of having this experience, this isolation of having to be at home, the loss of income because of job loss, but it's also the loss of accessing healthcare. And while we did a great job, I think, in many ways of expanding access through telehealth services and all the technology that happened from that standpoint, it certainly didn't reach everybody that needed to be reached. And so I think, yes, that we're going to have a significant problem going forward with mental health and access to treatment, because that's where we were before, unfortunately. And this is just going to exacerbate the problem. And I think it's definitely something that's going to be a part of how we can really go to that next step and be healthier in this community.
Dr. Meyers, one of our readers has a question about the potential impact on Texas of the COVID Delta variant. What kind of impact is that going to have, and how can vaccines help us battle this?
So the Delta variant is, just the latest emerging variant that is more transmissible, potentially more severe than the original wild type virus. And we're going to continue to see this virus evolve. And the best thing we can do as a state, as communities, is get as many people vaccinated as possible. Our vaccines, our mRNA vaccines, seem to be highly effective against most of the variants that are circulating. They protect people against getting severe disease, against ending up in the hospital or dying from the virus. So the best thing we can do as a society to protect against the variants is to get as many people vaccinated as possible.
Thank you for that. And I can talk to you three for hours about this stuff, but we are unfortunately out of time. So I want to thank you for tuning in, all of you, and thank you to Dr. Ancel Meyers, Dr. Carlo, and Dr. Meléndez for joining us. For more coverage from the Texas Tribune and the latest updates about COVID in Texas, visit texastribune.org. Thank you, everyone.